My talk will be about a project we just finished a few weeks ago. And well, the background of this project was there was an expert meeting in the German Ministry of Health, and there were members of health insurances and pension funds. And when I presented about a more or less qualitative study on family members affected by addiction, and that there are effective treatments available, they said, well, but you have to prove that this money is not spent in vain. So they asked us to do research on effectiveness of family-based interventions, and this is the key of what we've been doing in the EVIVA study. First of all, I'll start with my conflicts of interest. All research I've been doing has been funded by public institutions. I've served as a PI several years ago in a randomized controlled study on the community reinforcement and family training, and I've been conducting workshops on this method since 2006. And yeah, now to our research. All of you who haven't attended the first Affinet webinar held by Richard Wellerman are strongly advised to watch it on our YouTube channel, since effects of addiction on family members have been reported since a long time. So this is a postcard from the temperance movement in the Netherlands from the turn of the century to the 19th, 20th century. And you can see the father is on his way into a bar, and well, his wife is crying. The daughter is trying to prevent him from going there. So the harm addictive behaviors have been doing to families is well known for a long time, but only recently, in the last, well, say 20, 30 years, there has been an increase on research on this topic. And of course, this research also is strongly associated with many, many Affinet members, just to mention a few: Jim Alford, Richard Wellerman, and Lorna Templeton. So I won't repeat everything Richard has been saying. My structure will be, I'll have a brief outline on the background of the study. We'll tell something about professional help for family members affected by addiction. I will call them AFMs. And then I will present on the efficacy of interventions for AFMs. We'll briefly outline the implementation we have in Germany, and then we'll line out a discussion what all this means regarding science, treatment, implementation. So in Germany, we've done a general population study a few years ago, and 9.5% of the adult population, it was a representative population sample, reported that they had a family member with an addiction problem except for tobacco, which would mean we have something like an estimated 8 million adult inhabitants of Germany who are AFMs. And we know from a lot of studies that family members report a reduced health status. They have got elevated prevalences of affective and anxiety disorders. There have been loss of productivity and victimization reported. So it's a highly vulnerable group. And what is happening with this group has been described in the stress-strain coping support model Richard has been talking about in October, which means that, of course, addictive behaviors impose stress on family members, and to which degree this stress leads to strain and ill health depends upon informal and formal social support and the coping style of family members. In addition, stigma in addiction is a big issue, and we've been talking of a double stigma family members are faced with, because it's not only that addiction is stigmatized, but also being a close one to someone who suffers from addiction also has got a certain stigma, which is problematic concepts such as the codependency model, which in turn leads to barriers for family members to seek help and support. And many existing, especially lay support structures, are restricted to the concept of loving detachment, which just means separate from your addicted family member. In addition, we know that many people suffering from addiction live in relationships. These are data from outpatient addiction treatment in Germany, and you can see around about 40% of all treated individuals have children. More than 50% are living together with others, and also approximately about half of them is living in a partnership or has got a partnership. In the inpatient addiction treatment system, the numbers are more or less, so you could say around 40–50% of individuals with addictive disorders have children, are living together with others, and have a partner. In addition, I would also like to mention that this is just the tip of the iceberg. So many more family members are related to individuals who never get in touch with the treatment system. Regarding professional help, there are only a few help offers for family members, and there are a lot of barriers, so only very, very little family members seek help, especially if their addicted family member is not in treatment. And as part of a AFINET related project, we've been reviewing political or scientific guidelines on addiction, and we found that their family members almost never are mentioned, and also evidence-based approaches to help them are not part of most of these guidelines. As part of our EVIVA project, we were able to sample a few expert interviews from various countries, and as a result were that in most countries, if there are offers available for family members, most of these offers target children. Adult family members are mainly neglected, and in several countries, almost everything which is available to them are self-help groups like Al-Anon. And where specific treatment options are available within the treatment system, these options quite often are just a part of projects, which means it's scientific evaluation, and after 2 or 3 years, these concepts are not available anymore. And only a few countries report that support for AFMs is part of institutionalized, publicly funded structures. So it's a big issue how much resources are spent for affected family members, and in most countries it's almost nothing. It's part of, well, charity organizations and of volunteers. Furthermore, we have seen a large increase of digital formats for family members, especially since the COVID pandemic started. And we've also watched an increase in commercial offers for family members. So the current situation is rather devastating. And if we look at interventions that are evidence-based, there are, well, quite a lot of systematic reviews available, but most of these are restricted to specific interventions like craft or multidimensional family therapy. And like I already mentioned, this was the background for our systematic research in the EVIVA project. And in addition, we also had these international expert statements, and we had a survey among German practitioners where we wanted to find out what kind of interventions they know and what kind of interventions they practice. The aim of the whole thing was to identify deficits and to generate hypotheses for improving services for family members. As part of our systematic review, we defined that we were interested in studies on AFMs and peers of individuals with addictive disorders. I would call them IADs. And the intervention had to focus on AFMs as part of treatment of the IADs or on their own. And we were interested to have data on effectiveness of the intervention. So at least a pre-post test comparison had to be included. And we were looking at the specific outcomes, either outcomes regarding the dependent individual, the AFM, or dyadic concepts that can be attributed to the intervention. And we included publications in German or English language. In addition, we tried to rate the study quality based on the GRADE model. And we were especially looking whether it was a randomized controlled trial, whether there was an adequate control group, random or case control, whether the sample size was sufficient, the duration of the follow-up period, whether outcome assessors were blinded and adequate follow-up rates were achieved, and whether intention to treat analysis were. And so this is the study selection we had, and I think it might be difficult for you to read, but as you can see, we searched PubMed, Web of Science, and PsycInfo. And in addition, we also had a secondary search where we included literature found from the reference sections of reviews identified via this search. And altogether, we reviewed 5,891 publications. And in the end, we analyzed 243 articles, which belong to 188 studies. Here you can see, this is in German, but we extracted the main content of all studies by looking at what kind of intervention was conducted, when was the study published, and in which country the study was conducted. Aspects of study design, sample size, and diagnostic criteria. Then we had main findings and also some criteria regarding quality of the study. In addition, we had a briefer table where we were looking at well, sample size, duration of follow-up, design, control condition, what kind of effects were reported, what kind of substances were included, plus some other methodological issues. And in the end, we made a kind of global rating of study quality. We followed an article of Capello and colleagues where we tried to differentiate 3 different types of intervention. One was type A. These were interventions aiming to influence the addicted individual, mainly in order to seek treatment, which were interventions for family members outside of the treatment system. Then we had type B, involving AFMs into the treatment of the addicted individuals, and type C, interventions for AFMs in their own right. And since we also identified a 4th kind of study of interventions which fit in these 3 interventions, these were studies for addicted individuals which aimed to positively influence other family members. These were mainly studies for addicted mothers of small children or addicted parents in order to reduce strain and improve the parenting skills. So we call these kinds of interventions type D. Regarding type A, family-based interventions aiming to influence the addicted individuals. These interventions strongly rely on increasing treatment entry, but also as an alternative to support abstinence after the IID has been in treatment. But also most of the studies we reviewed, they included as a small part interventions to improve the well-being of AFMs. We identified in this arm 26 studies with moderate to high quality. And most of these studies reported outcomes that focused on the addicted individual or the family members. Samples were mostly recruited by media solicitation, and the majority of studies was on the community reinforcement and family training. And as main findings, I would say that we found consistently positive effects regarding the addicted individual. This should be IAD. But we found no differences between these interventions and active controls regarding the AFM or dyadic outcomes, which means, for example, if Kraft was compared with other interventions like Al-Anon, we had a significant better outcome regarding treatment entry of the IP, but no differences regarding the well-being of AFMs. Like I said, Kraft is the most prominent intervention among these type, and it's for all of you who are not familiar with the interventions, it's purely behavioral treatment for family members of treatment-reluctant individuals, usually with a duration of 12 weeks. And it focuses on improving their own well-being and motivating the IID to reduce substance use and to seek treatment. And it's strongly based on contingency management. And as I said, most positive outcomes yielded on most positive outcomes have been found in the field of substance use disorders. Results are less clear for pathological gambling. And most studies have been conducted in the US. So another important question is, to what extent does the treatment system influence the outcomes? This representativities of the samples are questionable, since usually it was asked whether people are interested to get their IPs into their IADs into treatment. And as part of our own study, we found that the outcomes vary depending on the baseline treatment motivation of AFMs. And like I said, no superiority compared to active controls. And a recently published study also found large effects when craft-based self-help materials were compared with an in-person craft treatment. Regarding the second interventions, these are interventions aiming for family members where the IAD is already in treatment. And they focus on improving treatment compliance and developing functional strategies against relapse and to improve interpersonal communication. We found 113 studies with usually moderate to good quality. And most studies were therapy and family therapy. Most studies on couples therapy focused on alcohol, most studies on family therapy on addiction problem for illegal substances. And most outcome reported focused exclusively on the individual with the addictive disorders. Most samples were recruited in treatment centers, and 23 of these studies were on behavioral couples therapy and further 10 studies on multidimensional family therapy. But altogether, most studies identified were single approaches where just 1 or 2 studies were conducted. And we found consistent effects on the dependent individual, but moderate effects on dyadic measures or measures regarding the family members, and no consistent effects when active controlled, where active control groups where partners also were included were a part of the study. Behavioral couples therapy, like you can hear from the name, mainly involves partners. And what is interesting, almost all the time we're talking about affected family members seeking help. We're talking mainly about females. Most of these studies have been conducted in the alcohol field, and focus of the intervention is reinforcement of abstinent behavior, but also improving relationship quality and communication training. Most interventions, well, are rather large scale, so 12 to 20 sessions over a duration of 3 to 6 months. And like I said, mixed effects have been reported regarding the well-being of AFMs. And also here we found no superiority when these interventions were tested against active controls, which also included partners. The other treatment, the multidimensional family therapy, mainly focused on parents. It's a combination of sessions with parents only, family sessions, and sessions for the individual with the addiction problem only, mainly used for adolescents. It's based on structural strategic family therapy. And as part of the parent domain, it aims to improve parental teamwork and skills and rebuild the parent-teen emotional bonds and enhancing the parent's individual functioning. Also, rather long duration of up to 6 months. Consistent effects have been found on the individual with the addiction problem, except when it was compared to other evidence-based methods. But only few of these studies reported outcomes on the level of the family members that were included. Then we got type C, interventions for family members in their own right, which focus almost exclusively on improving the well-being of AFMs. And these interventions focus on issues like goal clarification, improving self-care, gaining independence, and improving resilience, especially when children are in the focus. We identified 23 studies, and what we found interesting, these were the youngest studies we identified, with rather mixed methodological quality, which is due to the fact that there were quite a lot of only pre-post studies and fewer RCTs. The outcomes reported in most studies focused exclusively on AFMs, and many of these studies were identified via the secondary literature search. And we found consistently positive effects on the well-being of AFMs, but also only when passive controls were used. And well, a method that is especially well known among AFINET members is the 5-step method. And like I already mentioned, I would recommend all of you to watch the webinar of Richard Wellerman. And this method is very flexible regarding its applicability. So in the studies, quite often it was only 5 sessions. Its results are applicable as well to individuals, to family members of individuals with alcohol and drug problems. The effects are consistently positive regarding baseline to follow up, but there was only one published RCT identified by us that showed no significant difference between a brief and a longer version of 5-step, and no other comparison groups were included. I would also recommend all of you to put the next webinars in your calendar. I will also talk briefly about them at the end of my talk. So in January, Minna Ilva will talk about help for children of problem drinkers in Finland. Then in February, Cassandra Borges-Bortolon will tell us something about motivational interventions for family members living with a relative with substance-related disorder. This talk will be in Portuguese, but hopefully we'll also be able to get an English translation. And in May, Lorna Templeton and Jan Larkin will talk about the implementation of the 5-step method in England. Type D. These are interventions mainly focusing on addicted individuals with young children, mostly mothers. They focus on parenting skills, on other issues like managing emotional distress and improving attachment to the child. Quite a lot of these interventions have been tested and are offered in correctional settings. And we identified 30 studies with mostly high methodological quality. There was no dominant type of intervention. Most studies reported outcomes focusing on the addicted mothers, and quite a lot of studies also included dyadic or AFM related outcomes. AFM in this regard are the children. And studies that focused on effects on the children consistently found positive effects, while effects on the addicted mother usually were not significant, but this is due to the fact that also the control condition received usually evidence-based interventions. One intervention with this regard would be mothering from the inside out, which I found especially interesting because this was an intervention for mothers with usually drug use problems of very small babies. It was about duration of 12 sessions, and it aimed to improve reflective functioning, which included mentalizing for the own needs and the needs of the children. And this was augmented with psychoeducation regarding parental skills. And these 2 RCTs identified found consistently positive dyadic effects, but no effects regarding parental substance use. Regarding type D interventions, I would also like to recommend the AFINET webinar in April by Anne Whitaker, which she will also be talking about a study on type D intervention. So in the next step, we were interested to find out what do German treatment providers know about interventions for family members. And we conducted an online survey. In Germany, interventions for family members officially are part of routine care in the addiction treatment system. So we were looking for individuals who have been working with AFMs in the last 12 months. We chose several recruitment channels, among these the German Center for Addiction Issues, and we recruited from March to August. And in the end, we had 352 complete data sets. And since multi-vote was possible, 293 respondents said they were from, this should be outpatient, from outpatient facilities, and 81 reported to work in inpatient facilities or day clinics. So a small group was working in outpatient and inpatient facilities. And most reported to work with AFMs affected by alcohol and to a lesser degree by illegal drugs. Behavioral addictions were not that important. And what we also found interesting, that about 1/3 of respondents, they characterized the funding of work with AFMs to be inadequate. And only about 1/3 reported to have participated in specific training measures for working with AFMs. And regarding the various concepts, you can see here, the blue bars are, I know this concept and I use it in my work. The orange bars are, I know about the concept, but I don't use it. And the green bars indicate I don't know this concept. And as you can see, most practitioners, they know Al-Anon, but they do not practice this. Then we had craft, which was at least known by more than 50%, but only about 1/4 actually reported to use it. Behavioral couples therapy was virtually unknown. Multidimensional family therapy was a bit more known, but also not practiced very often. Other interventions like the 5-step method also are virtually unknown. What you can see further on the right hand is, for example, Etappe and Trampolin are interventions that were developed in Germany and aimed for improving the well-being of children affected by addiction. And then, yeah, we got some other issues. Interestingly, all concepts that haven't been translated into German are virtually unknown. So to come to my conclusions, we would say that family members affected by addiction have received more attention in the last 2 decades. Especially, they're a relevant, vulnerable group in need of support. And there has been an increasing number of intervention studies for them in their own right. What we found about the interventions was consistently that there are positive effects on the course of addiction for the addicted individuals. There are positive effects on relationship happiness between family members and the addicted individuals. And there are consistent positive effects on the well-being of family members. Furthermore, There are positive effects on parenting skills when parents suffering from addiction are specifically trained in parenting skills. What we also found interesting was there was a high level of evidence for cognitive behavioral interventions as well as for systemic interventions or interventions based on family therapy. There was no reliable evidence supporting the superiority of specific interventions regarding the improvement of the well-being of family members. And regarding the health system, we would conclude that on the one hand, family members should routinely be offered an opportunity to participate in the treatment of the addicted individuals if they want to do so, and support for family members independent from the addicted individuals, and this is the largest group of family members affected, should be offered and promoted nationwide and also should be adequately reimbursed. There are some methodological issues we found interesting we would like to share with you. One issue is a typical constellation is that when we talk about family members in the field of illegal drugs, we're mainly talking about parents. In the field of alcohol, it's mainly partners. Almost in all studies, AFMs were almost exclusively females. And what we also found interesting is that we found only a few studies that reported effects of the interventions on the family members, the addicted individual, and dyadic aspects between family members and dependent individual simultaneously. Furthermore, the diagnosis of the addicted individuals are not always reported clearly, which also might have an influence on adequate treatment, whether family members are in an early stage of addiction or are more or less chronically affected. Only a few studies report long-term effects above 12 months. And only few studies used objective outcome measures or blinded assessors. And what we also found interesting was that the distinction between type A and type C, which means interventions aiming to influence the addicted individuals and interventions aiming to promote the well-being of family members in their own right. We found the distinction to be rather difficult since there have been some interventions like behavioral exchange systems therapy, which in the original Capello paper have been part of intervention type Z. But since this intervention also relied on craft elements, we took it to intervention type A. So we would assume it's a continuum ranging from interventions which focus exclusively on the addicted individuals and more or less instrumentalize family members to get them into treatment on the one hand, like, for example, pressure to change approach, up to individuals that interventions that focus exclusively on the family members, like the 5-step method. Open questions, and I think there's still quite a lot to do in the field of research, is to find out first, which intervention suits best for which type or which group of affected family members. So where do we have a clear indication? Also, qualitative research suggests that family members vary according to their needs, and something like the severity of the addiction might heavily influence appropriate support. A second important question is, what are mechanisms of action of family-based intervention? As you might know, there's a large debate about this also in the field of motivational interviewing. So are there technical issues, which appears questionable in my understanding, since, like I said, cognitive behavioral interventions appear to have the same efficacy as systemic interventions, or is it more or less rather something interpersonal, which leads to effects like, for example, non-judgmental listening? Then we got the issue of feasibility. What is the most effective way of supporting family members in a given treatment system? Many interventions were quite lengthy, like I said, 12 sessions up to 6 months or so. So this won't be possible in all treatment systems worldwide. Strongly related with this question is the issue of dose-response relationship. And what I found interesting is several studies, for example, on the 5-step method or also on the Kraft intervention, reported positive effects on specific self-help materials as well. And there has been an increase in digital interventions, like, for example, also in the field of craft, where we need to know more about how these works and for which family members they are appropriate. Especially those small-scale interventions, digital or self-help based, have got, might have the positive aspect that it's easier to access them without having to, get into the public with having an addicted individual at home. Another important question is sustainability. So what are long-term effects of these interventions? And also, what are long-term effects, whether the addictive disorder might be successfully changed or is still ongoing? And last but not least, aspects of implementation. What are the best ways of implementing support for family members? We found in our German survey that in non-English speaking countries, the first very important issues is all material that is not translated in the local language is more or less worthless and just an academic issue. So maybe for all non-English speaking listeners, this also might encourage you to translate materials in your language if you haven't done so. So, coming to an end, I think many of these open questions heavily rely to the aims of AFINET that are listed here. I won't read them out loud. But I think regarding the way family members are recognized, we haven't done very large steps since this postcard was published, but I think with baby steps, we're moving forward. And this also should encourage all of you who are not yet AFINET members to become so. Like Richard said, our application form is working again. So just visit the homepage and apply for membership. And this has been everything I wanted to tell about the project. And of course, sometimes barriers are much, less complicated. This is something from an older study where a wife of an alcohol-dependent individual said that she lacked public information where to go when she suffered. So sometimes it's also just an issue like providing information, but I think improving help for family members should go beyond that. And now I'll be happy to answer some questions, but before I do so, I also would like to tell you that thanks to Richard Velleman, we will have webinars for at least the first half of next year. It'll always be on Tuesday. You can find all the titles and also then the information on how to access these webinars on the website, afinetwork.info. And so I thank you for your attention and would be happy to answer questions or respond to comments.
Gallus, thank you very much indeed. What a really excellent, comprehensive examination, extremely clearly explained. That was really excellent. Thank you very much, Gallus. And I, although obviously this is an area I know quite a lot about, I learned a lot from that as well. So that was excellent for me. I'm throwing it open for questions. If you have a question, can you unmute yourself, obviously, and probably put your camera on for the time that you are asking the question. So I have some questions, but I'll just wait to see if anybody wants to unmute themselves and expose themselves on the camera. And not immediately. So let me go straight into, so I've got about 4 or 5, but I wanted to ask a very simple one to start with, which I think just a point of clarification. You were talking about active versus passive control groups, and I wonder if it might be helpful to explain what you mean by that.
Okay, so well, passive control groups were treatment as usual or waiting list groups, or also pure psychoeducation. And active control groups were anything where another kind of active treatment was offered to family members. For example, if you take the 5-step intervention you've been doing, of course, a specific brief version of 5-step is an active control condition. While in the Kraft trial we've been doing, we had a waiting list group, which is passive.
Mm-hmm. And you're finding, what you found from the review was that when there were passive controls, the intervention that was being tested often showed positive results. But when there were active controls, then there were usually no differences between the two groups. Was that correct?
Especially when there were active control groups, there were no systematic effects on the well-being of family members. So in type A, compared to active control groups, of course, treatment entry rates were far better for example, the Kraft condition. But on all other measures, there were no differences.
So in terms of the effects on the affected family members, there were no differences.
Right.
Okay, so that leads me, I suppose, to one of the questions I wanted to ask you, which was, what do you make of this suggestion that basically, if I were to summarize it very, very non-scientifically, if you do anything to help family members and support family members, it seems to have an effect, and almost irrespective of what you then do, it still has an effect. Is that so do we need to worry about doing anything more rather than just doing something versus nothing?
Well, I would assume that it strongly depends upon the living situation of family members. I think there are some family members for whom very brief interventions might be sufficient. But I'm not a big fan of a kind of one-size-fits-it-all solution. Like, for example, I just, as part of the discussion we had among the Afinet trustees, I just bought the book Beyond Addiction, which is a book for family members, which is strongly related to Kraft. And what I found interesting when I was reading it, there were some examples of family members, and I thought, well, this might count as addicted in the US, but in Germany, no one would label these individuals as addicted. Mm-hmm. And I also found it interesting when I wrote the comments on this book on Amazon. There were quite a lot of people who said, well, this won't help if you're together with a chronic alcoholic. So I just wonder what is appropriate for whom.
Mm-hmm.
And I think, to put it simple, like I said in my conflicts of interest, my personal background is more based on the craft issue, because I think this is what many family members want in the first instance. But I also have seen quite a lot of family members that, that were together with someone who had so severe addiction problem that they didn't achieve.
Mm-hmm.
I think the first important issue is goal clarification. What do the family members want?
Mm-hmm.
And in a second step, we need to find out, well, like I said, for example, the amount of support they need, which might vary also heavily. I'm deeply convinced that everything we're doing, if we're working with individuals, is not merely about technical issues. So I think we can learn two things. On the one hand, of course, all the data show that we at least need to provide something non-stigmatizing. I would provocatively say, no matter what. And in the next step, we have to check out, what do these concrete individuals need?
Mm-hmm. Great. Gallus, I want to come back on that as well, but Tracy, you've got a question or a comment yourself.
Hiya, Richard. I'm sure our paths have crossed many months ago.
Nice to see you again.
All right. So I was involved in, I came across AFNet earlier on this year, and I thought, right, I need to be involved. I need to understand what's being done. Affected member and a former addict, you know, myself. And I'm writing a book around alcoholism and how it impacts on families, you know, the impact on families. And one of the things that struck me in the presentation is the statistics, you know, around the, 9.5% who were reported having a family member, 8 million, you know, so we can guesstimate, can't we? 1 or 2 people per addicted, someone suffering from addiction will be affected. The figures generally just suggest, though, you know, for those who are already in treatment, you know, and as we know, there's a lot of people who don't recognise they've got a problem or even engaging in treatment. For me, I'm really interested in that double stigma, around families not being offered support in their own right. In Sheffield, I used to sit on board of trustees for AFM many years ago. And I used to sit on National Treatment Agency Board, representing carers on there, as they were referred to. And that's changed that's changed a lot of the priority, you know, with loss of funding and what have you. The priority has been substance misuse as opposed to family and carer. And I'm just thinking, I think there's still a challenge. Families still don't seem to recognise their support needs. And while ever families don't recognise their own support needs, we're still going to have to challenge and get in services to acknowledge that.
Mm-hmm.
So I'm just wondering what people's thoughts were around that. But if there's not a demand and people aren't asking for it, services assume that there's not a need. You know, because of the stigma that's attached, services will assume, you know, that there ain't a need for it. It's not a priority.
Mm-hmm. But for example, we also know that family members have elevated rates of healthcare utilization due to ill health. And I think, for example, I think we need to do two things. One thing is publicly to promote anti-stigma work regarding addiction as a whole, but also regarding family members affected. And on the other hand, I think we need to have people from the healthcare system to encourage family members to seek help. And I know it's a challenge, but the kind of how do we promote available offers is important. When I started doing workshops in Germany, I usually asked my workshop participants, just imagine you would have studied something sensible like a technical issue and not psychology and so on, and you just find out that a family member of yours has got a drinking problem. What would you do? And especially younger people usually say, well, I'd ask the internet. And then I ask them, well, have you done so? Many people haven't. But if you do so in Germany, you immediately get on the codependency stuff, which I think deepens the stigma. And I think it's important to hold something against these concepts, against these stigmatizing concepts that are still quite popular. So I think there are many different fields we need to work on.
Yeah.
Can I just agree with that very much, Gallus? I mean, it seems to me that your points about stigma, Tracy, are very well taken. And I think one of the problems about stigma is self-stigmatization. So that people, because there's a lot of stigma in society, both around people with addiction problems, but also around family members and families being the cause of problems. Because family members are part of society, they have the same stigmatizing views that society has. And so they self-stigmatize and they say things like, I shouldn't, or it's probably my fault. Where did I go wrong? I mean, I can't tell you how many times, and you must have heard this as well, from parents who say, where did I go wrong? Because
Richard. Sorry? My mother said it to me.
Yeah, absolutely. And then, as Gallus says, you go on the internet and immediately you're confronted by many models like the codependency model, which basically says, yes, you're right, it is your fault. You are equally as ill, you are equally as sick. This is a disease that you've got. And so it's easy to see why people do feel that they don't deserve to say, I need help. And also, of course, they don't really think that they should be, because the person that needs the help, they're clear, is the person who's doing the drinking or drug taking or gambling. And in a sense, there's all this I shouldn't about it. So there's a huge public education piece of work that we need to do over and above trying to get high quality interventions out there, trying to help people recognize that it's okay to say, I'm having difficulty with this. It's a really difficult problem. I'm not quite sure what I should be doing, how I might be dealing with this. I would love to talk to somebody about it. And just allowing people to actually say those things would be really incredibly helpful. Lorna, I know you have a question, so do you want to come in here?
Yeah, hi. Thank you very much, Gallus. That was absolutely brilliant. And hi, everyone else. I guess my question relates to interventions for family in their own right. So that particular category, I don't just mean 5-step, but that's obviously in the back of my mind. And it's a real challenge over here in the UK as it is elsewhere to encourage and facilitate particularly treatment services to embed interventions for families in their own right, at least in an equal way to those with the addiction issues. So I guess my question is for your thoughts, Gallus, on what could be done to perhaps improve that situation and encourage the likes of treatment services to do more and to respond to families equally when the data on impact and prevalence are really very strong. Just as I guess a follow-on to that, I suspect that part of the answer goes back to needing a stronger evidence base. And it seemed from your data that that's perhaps where there's currently weaker evidence, smaller numbers of studies, poorer quality and so on. And so it may be that the two are linked, in which case there's a further question, and what more can we do to encourage people to A, fund, but B, do the research that is needed in this area?
Mm-hmm. Well, I would, two things regarding the scientific issue. I think what we need is more RCTs. I've been just involved in the German alcohol guideline development, and if you're in such a process, then everything which is not an RCT, you know, is not of interest. So I would also say I'm absolutely convinced that, for example, if you test 5-step against the waiting list control group, you will have large effects, which, matter of fact, will convince some people who probably are not convinced given the evidence we have at the moment. Of course, I fully understand that I also don't like control groups too much, and I do not like to randomize people to interventions I believe that are not effective and are not helpful for them. But still, I think in the end, this would be more convincing, for example, for policymakers. Regarding the aspect, how can we implement it? What I found interesting as part of our international expert systems, I think this might also be, to a certain degree, a kind of a top-down process. For example, in Scandinavia, it's far more common that well, on some political level, it is just decided that this method needs to be, well, offered, I don't know, nationwide, whatever, and then it's done. So, because my impression when I was talking with practitioners, at least in Germany, is that I think quite a lot of them are open to offer this, but they need to have proper reimbursement. And like I said, only 1/3 of the practitioners in our online survey ever received training for working with family members, which means they're trained to work with addicted individuals, and then a family member comes in and actually they got no clue what to do with them, which also is, I think, absurd.
Yeah,
so,
that's the same here, yeah.
So I would really say there's a scientific, a political, and to a lesser degree, an individual issue. I mean, I know there are some practitioners who rely on the codependency model, but I think it's getting fewer and fewer. It was far worse when I started with this work because there was almost nothing else available in German language. So
I see that Jim wants to come in. I don't know whether you want to come in about this, Jim, but please do.
Yes, it is on this subject, really. It's on this question of evidence. You know, what evidence do we need? I mean, Gallus, thank you so much for your talk. I mean, I was sort of absolutely glued to everything you were saying from the very beginning. I mean, it was full of really, really interesting stuff, and I think it really does take us on all the evidence you've been getting. But I was just interested in the very, 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 very first thing you said, that this came about because you had a meeting with some of the people in Germany who I take it are responsible for deciding whether there is sufficient evidence to actually fund something. So it was people like health insurance providers and so on. So I'm interested to know what you think they need. I mean, are they going to be convinced by the evidence you've produced that actually a number of different family-oriented interventions produce good things for both the family members themselves and for the people they're concerned about who've got addiction problems, but there's very, very little evidence that one type of intervention will any other active intervention? Are they going to be convinced by that? Or do they want evidence that actually there is an intervention? You know, do they, you know, is it like a vaccine? You know, what is the evidence? You know, is the evidence from randomized controlled trials that there's a vaccine that works better?
Jim, even with vaccines, there's more than one.
Well, I want to, yes. So, what do they want to know? Because to tell you the truth, I am not at all surprised at your results, because the view that I have come to is that actually, if you provide something good for affected family members and you do it well and you have a good idea behind it, then that is going to have some effectiveness. But if you compare two interventions, very different, both of which have a good theory behind them and are delivered well, then you're almost certainly not going to find very much difference between them. And this may sound like heresy, but I suspect if your active control group was something that was based on the idea of codependency, there wouldn't be much difference either. And my reason for saying that is because I think if you offered something that was based on the codependency theory, the people who were receiving it would feel that someone was interested in what they'd got to say, was listening to their experience, didn't believe in stigma, but actually believed that it was important that family members be listened to, and they would be providing they would be receiving a good intervention. So anyway, my main question to you, what evidence do you think your health insurance providers, what evidence do they really need? Are they going to be convinced by the evidence you've talked about today?
Well, I think in Germany we got the specific situation. I mean, like in almost all countries where health offers are financed by health insurance, you need to have a diagnosis to get reimbursement for treatment, except in Germany now there is a kind of money the health insurance companies need to spend on prevention. And this was our intention, to say, if we can convince them that family members are a highly vulnerable group with elevated costs for medical treatment, where we got the health insurance data from the US, and offering specific treatment for them can effectively reduce healthcare costs and burden, then I hope this might be a strong argument. And I also think it's, and this relates to stigma. We have had quite a lot of successful work in Germany regarding improving the well-being of family members of people with severe psychiatric disorders or of people with dementia. And I also usually used to say, well, it's typical that we're talking about codependency, but not about co-dementia, although we know that dementia also is related to a lot of burden. And so I hope if we could get into this kind of topic and convince them that it's a population in need, and in the long term, they might even save some money if they intervene early enough, then at least I hope this might be a striking argument, but I'm not sure. We'll see.
Okay, it is coming up to 5:15, and 3:15, sorry, in the UK. Different time for different people in different countries, obviously. So I think we need to draw to a halt. Gallus, thank you very much indeed. We could carry on this exchange for a long time. I would love to come back myself on some of those questions and answers, and I've got a series of other questions here which I shall have to give to you another time.